Dr. Santosh Honavar, Recent Advances on Conjunctival Tumors. And we are honored to have Dr. Millie Shakur, who's the professor of National Eye Institute of Ophthalmology in Bangladesh, as the keynote lecturer of the session. And we are extremely honored to have you here, Dr. Millie. And Dr. Millie is trained with Dr. Santosh Honavar in ocular oncology, and she does excellent work in ocular oncology in Bangladesh. And over to you and welcome.
Thank you, Dr. Fairuz. Good afternoon, dear colleagues and my mentor, Professor Dr. Santosh Honavar sir, and everyone here. Greetings from Bangladesh, and I'd like to express my thanks to AIOC-IC434-Recent for inviting me to deliver keynote speech in this session. I'm working in National Institute of Ophthalmology, and also as a consultant, I work in Bangladesh Eye Hospital, Uttara. So I'll be sharing how I have started to establish a center on ocular oncology in Bangladesh from zero to a established center now. So ocular oncology or eye cancer is an emerging subspecialty dealing with the study and treatment of tumors that occur in and around the eye. We all know that. But in 2000 till 2013, there was no structured oncology services in Bangladesh. So people, ophthalmologists and oculoplastic surgeons were dealing with the tumors, but no specialized center. In 2014, I had the chance to do my fellowship in ocular oncology and oculoplasty at Center for Sight under Dr. Santosh Honavar sir, and it was the gateway to this specialization. And it was not recognized as a separate specialty till 2014. And in 2015, we have repeated meetings, and we try to make understand the authority to accept it as a unit at National Institute of Ophthalmology, and they identified as ocular oncology unit at my institute. So we started doing ocular oncology, and there are just, I will quickly go through some of the cases and just to let you know that what we started doing at that time. So it was some lead growth, and we did multiple modalities of treatment or surgery, and then finally this outcome was got. It was a basal cell carcinoma, and it was also a lead growth. And there are so many, but I have taken few cases to show you that what we are doing after that, after this training. That kissing nevus we did, and then OSSN, first only emanating membrane graft, and then with mitomycin C, and finally we regularly use interferon alpha 2B now. So step by step we are moving to the global standard treatment. But we don't have plaque brachytherapy, so I'll be coming to that point. And cavernous hemangioma, we did just orbitotomy, and this optic nerve glioma, non-Hodgkin's lymphoma. Lymphangioma we treat with injection bleomycin, and with excellent result. Some of the cases come to us, extensive cases, we have to do exenteration to those patients. So we just treat, but we don't let this patient go, because we have learned to treat cases comprehensively. So we established a network and collaboration with National Institute of Cancer Research Hospital and National Neuroscience, National ENT Institute. So our cases are dealt with comprehensively in these 4 hospitals, and if needed in other hospitals too. And we have experienced histopathologists so all our cases are dealt with a single histopathologist, very experienced one, and if needed we take second opinion from other histopathologists and treat them. But challenge was to treat retinoblastoma, because retinoblastoma patients, there are multimodality treatment, and this patient presented with indifferent this kind of presentation. We took computer CT scan we did, and B scan, ultrasonography, all the patients we do this for documentation, and also it helps us for counseling also. And we follow international classification of retinoblastoma, Shields classification in our center, and international staging system for retinoblastoma. But till 2014, we had nothing. And we were just getting referral cases because people knew that someone came from Dr. Santosh Honavar, sir, trained from Dr. Santosh Honavar, and she knows retinoblastoma. So patients were coming, but we had nothing to give them. We just did EUA, and we grouped the patients, and we referred the cases to Pediatric Oncology Department of National Cancer Institute for chemotherapy. And some of the cases, which group E cases, we did enucleation with orbital implant when needed. But the challenge was follow-up. Those patients were not coming up from that center. So we used to give prosthesis from day one. All the patients got prosthesis. So referred patients were not coming back for follow-up. That was crucial. And those who were reporting had incomplete chemotherapy, like they took one chemotherapy and they didn't go for follow-up, then again irregularly they took another cycle. So we decided to start chemotherapy at NIO. At that time, in 2015, this is my first case who got chemotherapy, and at that time we had to give chemotherapy. The patient had to buy the chemo, and we used to give the chemo here. So it was a little bit expensive for the patients. So intravenous chemotherapy at National Institute of Ophthalmology. And other modalities of chemotherapy also we started, periocular chemotherapy and intravitreal chemotherapy at that time. But it was very expensive for the patients. These are the cases here. You can see that group D RB is cured with intravenous chemotherapy and intravitreal topotecan. And this is group B RB, regression with intravenous chemotherapy. This is also regression, group C RB treated with intravenous chemo. Then we thought that we have to have a comprehensive center for retinoblastoma in Bangladesh. So at that time we had these treatment options like cryotherapy, laser photocoagulation, and enucleation we are doing, and intravenous chemotherapy. So we wanted to understand our authority to make it a center with all the treatments available. But it was not their priority. Their priority was cataract, and cataract. They wanted to buy the big phaco machines, microscope, and everything needed for a phaco and vitreoretina, but not for retinoblastoma. So the negotiation was very crucial, and I didn't give up. I was counseling them and telling them we need it, that's all. And in 2017, they recognized as a separate department for retinoblastoma, that retinoblastoma unit, and we have now dedicated OT day and chemo day, dedicated inpatient bed for RB. We can admit the patients when those patients who comes from different rural places, and dropout reduced to minimum. So 2017 was a very important and crucial year for us. And 2019, we procured transpupillary thermotherapy, and also one thing happened in National Institute of Ophthalmology. Governments gave supply of vincristine, topocytin, carboplatin, and topotecan. So we don't have to wait for chemotherapy anymore. So it was a new era started in the treatment of RB in Bangladesh. So this is TTT, my first case. And after TTT, the results became very improved result, and tumors regressed, and all good news started coming. So we also gave intravitreal topotecan when needed. So it was a dream, because I dreamed, because my mother died from cancer, and as an ophthalmologist, I can also be a ocular oncologist. So that was the thought for me to become a oncologist. But that dream we have to have was continuing. What I can do more? We needed RADCAM. We want plaque brachytherapy. We wanted to start intraarterial chemotherapy and want to do research in genetics of our retinoblastoma in Bangladesh. But dream is dream. Different modalities of chemotherapy had, you can see in the, till 2021. We were giving everything, but intraarterial chemotherapy was not possible at that time. Then, 2021 January, it was 25th January 2021, we gave our first intraarterial chemo, and but unfortunately, they didn't follow up and the result was not good. But then we gave another 2 and they are doing well. So step by step, at National Institute of Ophthalmology, Ocular Oncology and Retinoblastoma Department was established. Still, our dream is we want to have RADCAM. But how we are doing that without RADCAM? Because we take montage photograph of the fundus and we compare those every month. In that way, we are just that expensive RADCAM we don't have. Plaque brachytherapy, we are on the way to procure it. Hopefully we'll get, because now I thank Dr. Santosh Honavar sir, because due to his good intention, now we have made in India plaque brachytherapy, and hopefully we'll get it soon. And we are planning some research in genetics of RB in Bangladesh. We are talking with a center in USA, so maybe very soon we'll have that research started. And we also have networking with blind schools. So those who have bilateral RB or vision, poor vision, they are enrolled in these schools, and so they will be in the mainstream of population. So in conclusion, nothing is impossible. Says you have to have a dream, and need to work step by step to fulfill that dream. And you have to have a mentor also. And I have a mentor who helps me in every step of my treating this retinoblastoma or oncology patients. So I'm very thankful to my mentor. And one thing for the young ophthalmologists, so dream big, but start it small, and step by step you can achieve what you dream. In Bangladesh, we can manage RB more confidently, and we can say that, inshallah, we'll move forward. And this was my first chemo patient. She's surviving, and she's very, now 8 years old, going to school, and one eye, she has good vision. And my team, without a team, we can't do our work. And this is me with my mentor, and in this occasion, I like to thank my mentor for his continuous support, for his inspiration. Now, I can do, and I can establish this center at National Institute of Ophthalmology and can serve so many people. Thank you, sir. And also, I'm doing it in National Bangladesh Eye Hospital also, establishing another center now on the way. So, thank you, sir.
Thank you, Millie. Thank you for dreaming big and working towards it. We start the instruction course now. That was a keynote lecture by Dr. Professor Millie Shakur. Dr. Fairuz will speak on benign and malignant epithelial conjunctival tumors.
इधर नहीं आ रहा है. हम्म?
Conjunctival tumors before Dr. Fairuz resolves her IT issues. क्या हुआ?
Good morning, everybody, and thank you, sir, for this opportunity. So, while Fairuz was supposed to give introduction about the tumor, and begin with the epithelial tumors. That's okay. We'll start with the other type of conjunctival surface tumors. Oops. Yeah. Huh? This wire is loose actually. No. So this wire is loose actually. Abhi, why is it not? Now it's coming. It's not showing there. It's coming there. So, yeah. So don't move it now. Don't move it. No, there is this loose wire which is there. Don't move it now. Yeah. Don't move it. Abhi aa raha hai, theek hai. Why are you moving? No, this is not the problem. The problem is this junction. This wire is loose. Okay. Is it coming? It's coming there. Now it's coming.
There's a loose connection going on here.
Actually, you see, this is loose. Wait. No. Is it okay? Is it okay? No? No. It is wrong. नहीं, give me that one only. वो जो आपने दिया था पहले. और इसको मूव मत करिए फिर. It's coming there. Okay. So don't move anything now. Okay, thank you. It's gone again.
Pen drive में करो ना.
Wait, one last shot. Just wait one minute.
अच्छा, इनका केबल का इशू है या अपना कनेक्शन का इशू? फिर हमारी ऐसे
Oh. This way.
So sorry. Well, so we'll try to catch up with time, and I'm going to start with benign and malignant conjunctival epithelial tumors. I have no financial disclosures, and these are my affiliations. So, well, just starting with the basics, conjunctiva is something that covers the ocular surface, and we have two layers, the epithelium and the stroma. So I'm going to deal with epithelial tumors of the conjunctiva. In fact, we also have epithelial cells. We have melanotic cells in the epithelium, and then we do have goblet cells. And stroma is composed of fibroblast, lymphatic vessels, blood vessels, and even lymphocytes. So depending upon the cells, the tissue, that's where the tumors and lesions arise in the conjunctiva. What I'm going to deal with today is epithelial lesions, and that too melanotic, where Dr. Vikas will be taking you through the rest. Mainly classification of these ocular surface tumors. We have benign tumors and malignant tumors, and I'm not going to go into the details of each, but we will see further, clinical features of each of these tumors. So the objective of this particular presentation would be clinical diagnosis and differentiating features. The characteristic clinical features and management will be dealt by Dr. Honavar. It's so very important as a clinician to identify these lesions, and I'm sure as a general ophthalmologist, as a cornea specialist, anterior segment specialist, and a specialist in ocular oncology, we all come across these ocular surface lesions, and most importantly, you need to differentiate between a benign and a malignant lesion. So these are the tick marks that I would give when I do a slit lamp examination of these patients, mainly the history, starting from history, age of onset, progression, recent or long-standing, which will give us a clue whether it's a benign or a malignant lesion, symptoms, location, surface, and most importantly, the vascularity of the lesion. Mostly when a lesion is very vascular, that indicates there is some amount of extra oxygen and blood supply going to the lesion for its proliferation, and that indicates it's a malignant lesion. Of course, mobility and fixity would let us know whether there is invasion or not. Now, this is a 72-year-old gentleman, gradually progressive mass in the lower fornix, and it has been growing for almost 2 years. And in fact, this patient was referred to me considering a possibility of a malignancy. And it's very, very clear-cut case where you can see kind of a cystic lesion, and he has undergone previous conjunctival surgeries earlier, right? So it's a very direct forward case, and this is what we do, a transillumination positivity test that we look for in cystic lesions, and this was an inclusion cyst of the conjunctiva which arises from the epithelium. So this was a very nice case. I mean, I've just seen one case of this all throughout 12 years in my tenure in ocular oncology, and it looked like a pearl actually. So she was pregnant and she came telling me that there is a pearl growing inside the eye, and absolutely it looks like a pearl, right? So this is a very rare case of keratin cyst of the conjunctiva, and I still have this specimen with me actually. All right, so a 32-year-old lady with eyelid swelling and fleshy mass in both eyes, and she says that her eyelid has been like swollen and full since childhood. Well, there is nothing obvious which is seen over here, and this is what I found. In bilateral it was there in the upper temporal quadrant, lower temporal quadrant, in the right eye, as well as in the left eye over here. I'm sure the audience knows the answer over here. What is it? Dermolipoma, yeah. So usually we talk about dermolipoma, which arises in the supratemporal quadrant, but this is again a very rare presentation where she had bilateral and multifocal dermolipoma. All right, excision was done, and this is how she looks like. So this is an HIV positive patient. He had ocular surface squamous neoplasia in his right eye, and then he comes with this lesion in his left eye. So being an immunocompromised patient, a young patient, he was 40-year-old. Well, the first thing that you would keep in mind is a malignancy, of course, right? Ocular surface squamous neoplasia. But this was more of a papilliform lesion. And of course, in my differential diagnosis, what I kept in my mind was OSSN, also probably a papilloma. Okay, and this came out to be a conjunctival papilloma. So conjunctival papilloma, yes, it is a benign lesion. It can be associated with immunodeficiency, and the most important association is the herpes human papilloma virus 6, 11, and 16. So it can happen in childhood as well as in adults. Usually it is seen in the inferomedial bulbar conjunctiva or the fornix as a papillomatous lesion. It will be pedunculated. It is usually mobile in the lesion, and also sometimes you find these diffuse lesions. So this was a patient who presented with a squamous papilloma in the right eye and a squamosal carcinoma in the left eye. So very sorry for these, the fonts over here, because there is a shift from Mac to the Windows. So it was a squamosal papilloma on the with all these mixed variety of epithelial tumors. Something called pseudo-epitheliomatous hyperplasia. We do see it in our practice. Often it mimics an OSSN, but it doesn't have a very characteristic feature of OSSN, which I will be taking you through. And these are elevated leukoplakic pink lesion, which arises, not many feeder vessels over there, which is not very characteristic of OSSN. And pathologically, this came out to be a pseudo-epitheliomatous hyperplasia. It's in fact an inflammatory proliferation of the conjunctiva. Well, so any take on the diagnosis over here? Very subtle lesion in the bulbar conjunctiva. In fact, this is my right eye. Yes, I have it. Shefali knows the answer. What is it? Acne keratosis. Okay, so excessive UV radiation exposure can lead to actinic keratosis. I has it bilaterally, and this is how very subtle it looks like. It is pre-malignant, but well, the chances of this turning into an OSSN is very, very low. But you have to keep it in mind. Patients might present with this in your clinic as well. So again, it is leukoplakic. There will be specks of keratin over the surface. It's gradually progressive and usually non-aggressive. Now, this was a patient who underwent an excision biopsy for an OSSN, referred to me after 2 weeks with this lesion, whether thinking that it's a recurrence of OSSN. Very unlikely to have a recurrence in 2 weeks, right? Yeah, so he had undergone an AMG also, which was placed. So what could this be? Pyogenic granuloma, yes. So it's very reddish in color, rapidly progressing lesion, and of course, recurrence is definitely ruled out in 2 weeks of that of an OSSN. We went ahead excising it and also topical steroids, okay? So it's fleshy, elevated, round or ovoid, and it can be pedunculated or even broad-based. This is a 70-year-old gentleman with white lesion in the theory, UVB radiation, P53 mutation, and even HPV infection has been attributed to it. Mostly perilimbal in location, as I told you, there is a transition zone theory where there is a transition of the epithelium at the limbus, and that's where it happens. So most importantly, you have to look for any lesion, even in the cornea or anywhere in the limbus, look for specks of keratin. It could be a very subtle OSSN, all right? Even in cornea. Now, systemic association, we have been, you might be seeing these cases in your clinic. Xeroderma pigmentosum patients, they can present at a very, very young age. This is a child with bilateral OSSN, and one was a squamous cell carcinoma and the other one was a carcinoma in situ in the left eye. Now, very rare syndrome. This is a case reported by one of Sir's previous very senior fellow of mine, Papillon-Lefebvre syndrome, where they have they present with OSSN at a very young age, congenital, hereditary. They will have palmoplantar keratoma and periodontosis. A very rare syndrome, not many cases reported. So conjunctival SCC is something that you have to really keep in mind. Never miss it in your clinical practice. It can be low grade, it can be aggressive, especially in immunosuppressive patients and patients with systemic association. Now, this is a very nodular lesion in the conjunctiva. Not very, very typical. It's like really nodular sitting there. Small lesion, of course. Feeder vessel is there. Some amount of rose Bengal staining and specks of keratin is there. So there are aggressive variant of OSSN, and this was a mucoepidermoid carcinoma, although very, very small. So nodular. It can present as a fleshy nodular lesion as well. The other aggressive variants are spindle cell squamous cell carcinoma and adenoid squamous carcinoma. So the characteristic features of an OSSN as an ocular surface tumor is the presence of keratin, rose Bengal staining, feeder vessels that you see here, intrinsic vessels which will be on the surface of the lesion, corneal encroachment, and scleral fixity. Now, how do you look for a scleral fixity? Well, this is how we do. Sorry, it's totally distorted over here because it's Mac to Windows. We take cotton bud tip and then try to move it in the clinic in order to clinically assess whether there is scleral fixity or not. Well, very important to avoid the eyelid of any of these patients who come to you, okay? So there can be a lesion sitting in the tarsus as well. So this was a patient who presented with OSSN of the upper tarsus. So clinical documentation is very, very important. Before the patient goes in for a surgical intervention, we actually, kind of map out the entire extent of the lesion. Although you see a very nodular whitish lesion over here, but the surrounding conjunctiva is thickened. That means the surrounding conjunctiva is also affected. And as I told you, it is a spectrum. So it can be a dysplasia there, it can be a carcinoma in situ, and a squamous cell carcinoma, which is seen nodular. Lymph node examination is again very important, preauricular, submandibular, anterior cervical, and the posterior cervical. So ocular surface squamous neoplasia comes in different forms: nodular, gelatinous, papillary, even pigmented, which can actually simulate a conjunctival melanoma, all right? Especially in our country where we are all brownish, we have, brown skin people. So this is totally, related to the cornea. There is nothing in the conjunctiva arising from the limbus going to the cornea, and this is a case of a corneal OSSN, which has been confirmed with the anterior segment OCT, where you have this tongue-shaped appearance arising totally from the corneal epithelium. Another very rare variant, this is a patient left eye. She has been treated for blepharitis for many, many years. It has not been, resolving. So any patient presenting with a very asymmetric blepharitis, some specks of keratin, you should always think of a diffuse OSSN. So this is how we diagnose. We take map biopsy and then we confirm how much is the extent of the OSSN. Now, role of investigation, yes. Role of UBN and OSOCT in those patients where one is corneal OSSN, of course, and other where you are suspecting a scleral invasion or an intraocular extension. Ultrasound B scan for intraocular extension. Any lesion which is like very large, and especially in the medial caruncle towards the fornices, always do a CT scan in order to rule out an orbital extension. So this is a 56-year-old lady with a swelling in the caruncle for the past 8 months. Any guess for the diagnosis? It's a very rare tumor, in fact, epithelial tumor, benign. You'll get a chocolate at the end of the session. Oncocytoma, who said that? Hands up. Oh, hi, I know you. All right, yeah. So this is a case of an oncocytoma. Very, very rare. Very few reported cases. And there are 15 cases reported of adenocarcinoma also. So there is a very rare possibility that a malignancy can arise from it. All right. Last case, 68-year-old gentleman with redness and irritation in the right eye past 1 year. Caruncle has all the tissues. It has got squamous epithelium. It has got sebaceous glands. It has got skin. Everything is there. So any tumors can arise from the caruncle. Any guess for this? What would you want to rule out? It's reddish in color, right? It doesn't look good. There is hemorrhage over the surface, right? So always think of a malignancy, and you know what this came out as? Sebaceous gland carcinoma. So yes, sebaceous gland carcinoma can also arise in the conjunctiva. Well, any guesses? Amelanotic, bilateral, near the limbus, some specks of melanin, long-standing, childhood. This is how it looks like. Cystic spaces, macrocysts, any lesion in the conjunctival epithelium with cysts, nevus. So this is an amelanotic nevus. I'm not going into the, Dr. Vikas is going to take over the melanocytic lesions. Well, this looks very amelanotic, but there are specks of pigment over there, large lesion. This was a very rare kind of a presentation of a conjunctival amelanotic melanoma, most commonly seen in the Western population. And this is a case which I had seen during my fellowship with Carol Shields at Wilsey Hospital. Not too common in India though, but just keep it in your mind. And thank you very much. It's a wide clinical spectrum. Over to you, Dr. Vikas.
Thank you, Fairuz. That was an excellent overview and a good introduction to the subject. So I'll now move to the next set of tumors, that will be the pigmented tumors. Why are we not getting this? Okay. So talking about melanocytic tumors of conjunctiva next. So what happens basically is that if you look at the histopathology of a normal conjunctiva, so you see these epithelial cells, and this is near the basal layer of these epithelial cells. This is where the pigmented cells lie. And so all these problems related to pigmented lesions of the conjunctiva either are arising because of some proliferation of the pigments in this layer, or because of the melanocytes taking on a more notorious route. So commonly what we see are as pigmented lesions of conjunctiva can be classified as one of these 4 lesions. Either it can be a nevus or a complexion associated melanosis, a PAM or a melanoma. Let's see how each of them looks like through some of those clinical examples. So this patient comes with a bilateral symmetric diffuse pigmentation irregular in the interpalpebral area, and it's referred to you for opinion as to rule out a malignancy because the pigmentation looks really dense and scary at times. But if you look carefully, these are both eyes of the patient. The pigmentation is very, very symmetrical on both sides. It's confined to the interpalpebral area, the fornices being clear. And you look at the general complexion of the patient, look at the face, and if it's a pigmented skin, then many a times these patients can also have increased pigmentation in the conjunctiva as well. So this is nothing to worry about. It's just a case of a complexion-associated melanosis, and you can reassure the patient. Next is a 6-year-old child brought by parents worrying about this pigmented patch on the surface of their child's eye, and they see some reddishness growing along, and the referring doctor also feels concerned because he feels that there is some prominent blood vessel which is like a feeder vessel going inside. What is to be done? So nothing is to be done. You just reassure the parents and the referring doctor because this is just a congenital nevus. And so what happens is that basically these lesions are mostly congenital. The pigmented cells are very small at birth, but as a child grows, they also keep growing. And at times of puberty, at times of pregnancy, and sometimes even with prolonged sun exposure, these lesions can increase in size. So how you can be reasonably sure that this is not a malignancy is if you can identify these small cysts within the lesion. Now, if you look under the slit lamp, you will see that these are clear fluid-filled cysts in the substance of the lesion. And so once you see these cysts, then you can be reasonably reassured that what you're dealing with is a benign lesion and it's not something to do with a malignancy. Although there can be lesions where the lesion, the nevus can evolve into a melanoma, and you may have some area where it's a pigment, it's a nevus kind of thing, and another area which is looking more notorious. But those are fortunately very, very rare. 99% of the times what you will see will be with the cyst will be a nevus. If you sometimes have difficulty in identifying nevus, you see the cysts on the surface, but you're not really sure, or the parents are a little apprehensive, you want to show the parents as to what it is, you can do an OCT, anterior segment OCT, and that's where you will see these clear cysts clearly. And you can document these for your own purpose, academic purpose. You can show it to the parents and everybody can feel reassured. Sometimes young boys with VKC or allergy, they will present and the parents will say that, this spot was there, but suddenly it has become more red. You're concerned and they say that, it's becoming and the parents are very apprehensive, so please take it out, please take it out. You take it out, and then when you send it to a pathologist, the pathologist reports it's an inflamed nevus. So nevi can get inflamed, especially in children who are prone to allergies and VKC and things like that. And you give a short course of topical steroids, the redness is likely to settle down, and then further on you can just keep on observing them or manage them, as will be discussed in the next lecture. So these are some of the typical locations where if you see a pigmented patch with microcysts, it's more likely to be a nevus. It's in the interpalpebral fissure near the limbus, the plica, or the caruncle. So these are the sites which are most commonly associated with the nevus. As Dr. Fairuz showed, sometimes you do get patients who are very fair-skinned, or some patients traveling from abroad and they are little concerned about the lesion on their eye, and it looks more reddish, and if you would to do a biopsy on them, you would find that it's an amelanotic nevus. How you find out is that this lesion again will have a clear cyst, which are unfortunately not very clear in this picture. So these nevi have a less than 1% risk of malignant conversion, but you should be aware of that possibility also. And when do you look for, or when do you think about a malignant transformation is if a patient is presenting with a pigmented nevus onset in adulthood, if there has been a recent growth or color change in an adult who has always had a nevus, and if it's a location other than bulbar conjunctiva, plica, or caruncle as showed earlier. If there are very prominent feeder vessels, very angry looking vessels, not like those tiny feeble kind of vessels that I just showed, melanoma will have different kind of more angry looking feeder vessels. And if you've excised one nevus and again it recurs with more pigmentation and some vascularity, it's a recurrence, then also you should suspect that. Now there are some systemic association, Carney complex and dysplastic nevus syndrome. Basically in dysplastic nevus syndrome, the patient will have nevi all over the body in different parts, and these are patients who are more prone to have melanomas also. Another commonly associated pigmented lesion that comes and presents in our OPD, I am sure all of you would have seen it at some point of time, and it's a diffuse, irregular kind of pigmentation on the surface of the eye. If you make a fine slit and look at this lesion, you will find that the lesion is not conjunctival, it's rather subconjunctival, and you can take a swab stick, as Dr. Fairuz again showed, you move the conjunctiva over it, and the conjunctiva will be free. This is basically episcleral or scleral pigmentation, which because of its level, because of its depth, appears slightly gray or bluish. And this is not a melanoma or a nevus, this is melanocytosis. That's a term which is used for such lesions. The importance is that they can be associated with involvement of skin as well, which is when it's called as ocular dermal melanocytosis. And if you have a patient of ocular dermal melanocytosis, always dilate the pupil and look inside. Few of them, although rarely, can have a choroidal or uveal melanoma as well. Also, if you ask them to open their mouths, they may have pigmentation of the soft palate as well, which may be associated with esophageal carcinoma as well. And also look at their hairline. If they have some pigmentation on the hairline, then they can also have a meningeal melanomas. So these patients where you have these kind of pigmentation, also refer them to an appropriate specialist for cross-referral to rule out other systemic complications. Then another patient who presents with a recent onset diffuse pigmentation, ill-defined pigmentation. Now this is conjunctival pigmentation, very ill-defined, very irregular, and the patient gives history that he's been having this for the last 6 months only, and it's been sometimes growing and sometimes it looks like it's settled down. So what this is basically what is called as primary acquired melanosis or CMIN, that's conjunctival melanoma in situ. So this is basically a superficial kind of pigmentation in the epithelial layers, and it's, as the name suggests, it's acquired, it's primary, it's mostly seen in middle-aged people, and you may get a history that it's increasing or decreasing in size and level. Now, these are the various patterns. Sometimes you see different patterns of this PAM, and if you are concerned, or if the lesion is large enough, then you may do a biopsy for these lesions. And then what is important is that the pathologist should be able to tell you whether this PAM is PAM without atypia or it is PAM with atypia, because both these things will have a different prognostic value for the patient. So if it's PAM without atypia, then there is no risk for development of melanoma. Then if it is a PAM with atypia that comes out in your histopathology, if the pathologist doesn't mention, and it just mentioned, the report mentions it is just PAM, you have to call up the pathologist and ask whether it's PAM with or without atypia. That's your job to ask them. If it's PAM with atypia, then there is approximately 46% chance of conjunctival melanoma. That's nearly 50%. So these are the patients where you need to be a little more aggressive in your treatment. And then there are other factors. If the atypical melanocytes are in the epithelium, which are located in other than basal layer, then it's almost 90%. So basically these are different factors by which pathologically, with pathological reporting, you can actually correlate the risk of development towards a melanoma and take appropriate action. Now sometimes a patient will come, an old patient, elderly patient on anti-glaucoma medications for a long time will present with a small line of pigmentation in the fornix. So don't worry about that. Keep the patient under observation. This can be because of the medication only. And if you change the medication, this sometimes can go away. And then other causes of pigmentation like Addison's disease also can cause a secondary acquired melanosis. So you need to differentiate between primary and secondary at times. And at times there's no harm in doing a biopsy if you have any doubts. So moving on to the most notorious type of pigmented lesion on the surface, that's the conjunctival melanoma. And most of these, almost 75% of these are associated with primary acquired melanosis with atypia. And rarely 20% may be associated or develop from a nevus, and very few of them arise without any of these pre-existing lesions. Although there can be some risk factors like dysplastic nevus syndrome or neurofibroma or xeroderma, as Fairuz mentioned for OSSN, these patients can also have, xeroderma patients can also have more of a melanomas. Now this patient presented with a pigmented mass, large nodular pigmented mass in the fornix, very deeply pigmented here, slightly less pigmentation here, more reddish thing. So this was a case, which probably had at some point of time some PAM, which was ignored, and that eventually developed into a melanoma. Another similar patient, I remember this patient, he was a doctor himself, and he had pigmentation for a long time, never bothered about it. and then one fine day, he comes that he's been seeing this nodule in the eye, and with deep dark pigmentation spilling over to the skin, and a large nodule which is lying in the fornix. You see all this pigmentation on this lid margin as well, on the surface of the lesion as well. This again is nothing but a melanoma. So what you have to do at this stage when the patient comes, it's already gone way beyond local resection, and we'll talk about management in the subsequent parts. Another patient you see with the diffuse deep pigmentation of the fornices spilling over to the lid margin, and also presence of these nodular thickening over the caruncle. It's kind of very thick nodule, very darkly pigmented. Again, you take a biopsy, and this was a melanoma again. So some of these cases which presented with PAM with atypia, as mentioned, most commonly that is the one which develops into melanoma. So you have to be really careful when you are seeing a patient of PAM with atypia. When to intervene, where to intervene will be discussed in the subsequent lecture. And these are really bad tumors, melanomas. There's a high risk of metastasis. This is Western literature, up to 9 to 25%. I'm sure in Indian subset we'll have even more higher risk of a higher proportion of metastasis and patients dying of these tumors. These are the common sites where they can go: lung, liver, GI. And also now we have a AJCC classification, proper AJCC classification, which is available for any systemic cancer. We also have that for melanoma. People who are interested in academic pursuits may go through this AJCC classification when they see a patient of melanoma. Mortality is also high. It's nearly 40% mortality at 10 years, 40 to 50% actually it is. So that's quite bad. And sometimes you have patients being referred to as melanomas, but when you have a close look at them, you see that this is like a lesion which has got some keratin on the surface, which has got some feeder vessels and some intra-lesional vasculature also. So with the presence of keratin, and you see keratin here and keratin here, so this was basically OSSN, as Dr. Fairuz showed in the previous lecture. And basically in Indian patients, at times we do get pigmentation on the surface. And again, another patient who may be referred to as a melanoma, but if you do a B scan and you look closely at this patient, this is nothing but a staphyloma, ciliary staphyloma. A young patient was referred for diffuse pigmentation of the conjunctiva here on the right side. And then you have to also ask proper history. So now this patient gave history of a via surgery done previously. So sometimes you may have a situation where the choroidal pigment leaches out through the port of VR surgery, and that can also deposit in subconjunctival space. And the surgeon got worried whether he has intervened in a patient who already had a melanoma or something like that. So nothing like that. This can also happen from a wound leak. So this pigmentation could be easily washed off and the port closed with another suture. The patient was doing fine. So briefly mentioning the stromal tumors. Stromal tumors are relatively less common than the epithelial tumors. So some of the tumors that Dr. Fairuz showed were also part of stromal tumors. Now this patient, a 40-year-old male, presented with this kind of a smooth reddish mass near the limbus and was referred as OSSN. But what will you notice here is that it's the odd thing about this lesion was it's relatively smooth, shiny. There was no keratin on the surface. There was no intrinsic. There were some vessels intrinsically growing inside. So my thought was probably it's a atypical kind of OSSN which does not have a keratin, or thought it's a localized form of a lymphoma. But anyhow, the treatment was biopsy, and to my surprise, what it turned out to be a neurofibroma. So neurofibromas are stromal tumors which are relatively rare, and but they can mimic or masquerade an OSSN, or sometimes if it's a smaller one, you may think it's a nodular inflammation of the surface which does not respond to topical steroids or the conventional treatment for episcleritis. So one can keep in mind the rare possibilities also, and ultimately the biopsy helps in the final diagnosis. Then we have lymphoproliferative lesions of the conjunctiva, and these lesions can be benign, like this was a young child presented with a pinkish mass, but you have to rule out a lymphoma. So you do a biopsy, it turned out to be a benign reactive lymphoidhyperplasia, and this is the malignant form, lymphoma. So especially if these lymphoma patients have a bilateral lesion, they have more chance of developing a systemic lymphoma as well. So you need to keep those things in mind, and also take into consultation a medical oncologist if you're dealing with a bilateral lesion. Mostly these patients will also have an orbital component, so you do a proper imaging and treat accordingly if it's a localized or a systemic lymphoma. Another entity which is recently described entity is conjunctival stromal tumor. So basically we know stromal tumors are like maybe neural tumors, maybe lymphoproliferative tumors or vascular tumors, but there is a set of tumors which does not fit into any of those categories. Basically histologically these lesions have spindle cells with a lot of myxoid stroma, and when you send them for a biopsy, they are benign tumors, but the important thing is that you need to differentiate them from myxomas, which may have a systemic association in form of atrial myxomas. So that's why pathology is important. You need to rule out a myxoma. Okay? If it's just a simple stromal tumor and not a myxoma, which can be differentiated with IHC and with pathology, proper pathology, then there is no further intervention required. So some vascular tumors, Dr. Fairuz showed pyogenic granuloma. Some other vascular tumors, this is like a varix, and this is a venolymphatic malformation. Basically, these are mostly extensions of the orbital components which protrude anteriorly. So I conclude here. Thank you very much. I hope I didn't extend from my time, allotted time. Thank you.
Can you switch? Yeah. After those wonderful talks on the clinical manifestations of ocular surface tumors, both stromal as well as epithelial, I'll be speaking on the management of ocular surface tumors. Now, imaging is very important in ocular surface tumors because oncological principles always mean that you excise the entire tumor. Otherwise, you have a higher chance of local tumor recurrence. While edge is easily determinable on clinical evaluation, a good slit lamp evaluation will tell you about the edge. How do you know the base? Base is something that is always a suspect. Slit lamp will not tell you very clearly about the base because you cannot see through the tumor many a time. Then comes the role of imaging. Of course, anterior segment OCT has some disadvantages because in the areas of keratin there is some shadowing. You'll still be able to estimate the depth of the lesion. Of course, diagnosis is also part of it. This is a beautiful picture where you can actually see the level of the lesion very clearly. You can see that conjunctiva is involved, this bubbly layer is the tenons. So your plane of dissection can just be there, episclerals. You don't have to do anything in terms of deeper dissection. So you know the plane of the tumor. And in this patient, there is full thickness corneal stromal involvement, which means that you have to either consider a penetrating keratoplasty or plaque brachytherapy. So depth of the lesion can be determined by either anterior segment OCT or UBM. All these patients have had UBM mainly because we suspected intraocular extension, which they all have. That doesn't mean that you enucleate them, you can always plaque them. Now coming to the most important modality of managing epithelial tumors, topical therapy, topical chemotherapy or immunotherapy. Mitomycin and 5-fluorouracil are chemotherapeutic drugs. Both are extremely useful, have been used over a long period of time in the management of ocular surface tumors. What is relatively new is interferon alpha-2b, which is immunotherapy. In between that is a specific use of cidofovir, which is hardly ever used. These are very specific cases of OSSM with HIV positivity where cidofovir is used. Indications I'll show you in pictures, but before that, if you want to have a head-to-head cost comparison, 5FU is least expensive. If you want to know which is the most effective drug, mitomycin. It is the most effective drug, but it's also not friendly to the ocular surface, causes corneal epithelial erosion, chronic conjunctivitis. Many patients are not able to tolerate it. Most friendly drug is interferon, but it takes time to work. So this is the fastest drug. This comes somewhere in between in terms of its effect and complications. This is the slowest drug, very gentle to the ocular surface. It has hardly any complications. Now there are three ways in which interferon can be used. One is immunotherapy, where your endpoint is complete resolution of the tumor. That is your endpoint. So you clinically determine which tumors are going to behave in a way that they completely resolve. I'll show you how to do that. Immunoreduction is a principle where, just like retinoblastoma, where you take a large tumor and shrink it down and then apply focal therapeutic measures. This is a way of reducing the size of the tumor so that you can do a minimal surgery instead of an extensive surgery. Immunomodulation is a relatively new concept where you modulate the ocular surface immunity to prevent new tumors from happening. This is so in patients who are immunocompromised or xeroderma pigmentosa patients where they crop up new tumors every now and again, they are prevented by using immunotherapy. Now this is a small tumor. This tumor has completely gone away with topical interferon. This is a very clear indication for topical therapy. Small tumors which are not really surgical candidates. Of course, if a patient wants a one-time cure, you can offer surgery for this patient. Another small tumor resolved with interferon. It takes about 4 to 6 weeks for small tumors. This was a patient who was excised earlier, has recurred, and that was again managed with topical mitomycin C. So recurrences where you already know the histopath. The most important indications for topical therapy is corneal OSSN. This is a patient, this is my favorite slide. My cornea specialist had done a biopsy here. Rest of the tumor was taken care by topical therapy. 3 years later, you can see corneal scar exactly in the area where he had done a biopsy, which means that there would be some subtle corneal scar if it were to be surgically primarily excised in the pupillary axis, thus precluding 20/20 N6 vision or whatever vision that the patient is capable of. So corneal OSSN, if you want minimal scarring or no scarring and good resolution, the treatment of choice is topical therapy. Surgery is secondary. This is a very clear indication for topical therapy. Now this was a patient who had xeroderma pigmentosum, other eye is lost already, and this is a third graft that the patient has, and exactly in the graft host junction there is a OSSN. So this is not a surgical candidate because even a minor surgical intervention here may tip the graft in favor of, say, graft rejection or failure. Here again we use topical therapy. The graft has become clear again, DM folds are gone, and the tumor is completely resolved. So one clear indication. Next indication is limbal extent of the tumor. Limbal extent because if the patient has more than 6 clock hours of limbal invasion, then possibly there is going to be limbal stem cell deficiency when you excise these tumors primarily, right? So if you want to prevent that complication, then you use topical therapy. You can see a scarless healing there, limbal stem cell barrier is absolutely fine. Next indication is diffuse OSSN. If the configuration of the tumor is like that, flat, placoid, rather than elevated nodular, this is very clear indication for topical therapy. It works most effectively when there is corneal OSSN, when there is flat tumor, like this. So this took only about 3 months for the tumor to go away without any stigma of any surgical intervention, scarless healing. Next is extensive tumor. Extensive tumor where surgery, only surgery that you can do is orbital exentration. You can offer them topical therapy in such patients. This is of course not 100% successful. Maybe half the patients will resolve with this. This is a patient who had palpebral as well as bulbar conjunctival involvement and resolved with injection interferon. So you bring in injection interferon when the tumor is more extensive and resistant to topical therapy. Clinically you feel that it may not respond to topical therapy. Then you inject interferon, which is 3 to 10 million international units every 3 weekly for about 3 to 6 injections. After that you decide whether you want to do any further surgery or not. HIV positive patient, diffuse OSSN, resolved with injection interferon. So injection interferon is a reality and it can be used judiciously in patients who deserve it. Whereas interferon is used as an injectable, mitomycin and 5-fluorouracil are only topical drops and they should not be used in injectable mode. Now immunoreduction is a principle. For example, if this is the tumor, that is the epicenter of the tumor. You know that OSSN is a tumor of the limbal stem cell. Around it would be a zone of carcinoma in situ, severe, moderate and mild dysplasia. So what topical therapy does is it does not work on infiltrative tumor, but it works on all else, carcinoma in situ and dysplasia, and what is left ultimately is the invasive component. So all that is left is this now for you to excise from a large tumor that you started off with. So you reduce the tumor and then shrink it down to the size that you can do minimal surgery. Immunomodulation is performed mainly for patients who have immunosuppression, either iatrogenic immunosuppression post-organ transplant patients or HIV positive patients, or for patients who have xeroderma pigmentosum. The next is about topical chemotherapy case selection. These are the advantages and disadvantages. I won't elaborate on that, but mainly topical therapy sometimes can turn out to be more extensive than one-time surgery. That you have to keep in mind, and also the compliance of the patient in terms of using the drop. Otherwise, it's not a good idea. When not to offer topical therapy, when the diagnosis is in doubt. You haven't been able to diagnose it clinically, but you still use topical therapy, that is not acceptable. Example is this patient who looked like this. Many of you would say that it is OSSN, but when you flip the lid, you realize that the lid margin is affected and posterior lid margin is rounded. Meibomian gland orifices are all lost, indicating that it is pegytoid sebaceous gland carcinoma, which is not a candidate at all for topical therapy. Now, this we covered already. When you're not sure about the depth, again, topical therapy should not be used. You should definitely make sure that there is no scleral or corneal infiltration before you start off on topical therapy. And when you're not sure about the stage, some of the articles generalize. For example, this article from a very nice group, what is written is 85% of T3 tumors respond to topical therapy. When you look at what is T3, AJCC, tumors that invade cornea, intraocular structures, pharyngeal conjunctiva, palpebral conjunctiva, tarsal conjunctiva, punctum, canaliculi, etc. are T3. How would that respond? Right? So just by looking at the abstract of an article, you should not start on topical therapy. These are advanced cases. They should not be started on topical therapy. Example is this patient where somebody started on topical therapy and the tumor promptly increased in size despite being on topical therapy. This was not a good candidate. And when you're not sure about patient compliance and a patient comes with a small localized tumor like this, obviously you can simply remove it with a 10-minute surgery. Why not give this patient 3 months worth of topical therapy? So patient unlikely to be compliant, has a small tumor, again you remove it. Adjuvant therapy should not be guided by guess. Many times I get consultations saying that, okay, I've removed the tumor, should I give topical mitomycin? So why should you give it? There has to be a reason. Only if the resection edge is positive, and that contains only dysplasia and carcinoma in situ. If you have already done edge cryotherapy, only observation. If you have not done edge cryotherapy, then topical chemotherapy only for dysplasia and carcinoma in situ. If the resection edge is positive with invasive squamous cell carcinoma, medico-legally you are bound to re-excise it. Otherwise, you cannot rely on topical therapy for an invasive squamous cell carcinoma. We know that already. If resection base is positive and if the pathologist can localize the particular claw cover of the base, then cryotherapy is a possibility. But if resection base is diffusely positive, then you have to resort to plaque brachytherapy. Let's go to surgery. Surgery, the most important concept is excision with tumor-free margins and tumor-free base. Margins clinically determined plus histopathologically confirmed, base determined by imaging and histopathologically confirmed. For the corneal epithelial component, use alcohol-assisted keratoepitheliectomy. Cryotherapy to the resection edge is mandatory. Every patient gets it. This is a kind of diagram we have to make and take to the OT or take digital photographs. Every detail mentioned, so that slit lamp diagram is the best. Once you give peribulbar block, sometimes there is conjunctival effusion resulting in poor definition of the tumor. This is a very straightforward surgery where you mark the edge of the tumor beyond 4 mm from the clinically determined margin. That means that you would have already done Rose Bengal staining to determine the extent of the tumor beyond that 4 mm margin. Then edge is excised using either a monopolar electrode or any surgical instrument of your choice. This is surgeon specific. Excision of the tumor, again from the base using, I use RF because I'm used to it for oculoplasty surgeries. I use the same instrument. Cauterize blood vessels paralimbally so that there is minimal bleeding. Apply alcohol to the leading edge of the tumor about 3 to 4 mm beyond the edge of the tumor so that the epithelium becomes loose. This is to preserve the Bowman's membrane so that you don't have to do dissection between the epithelium and the Bowman's. Epithelium becomes loose and you can simply scroll it off towards the limbus. We have already reached the limbus from the scleral side. Now we are reaching the limbus from the corneal side. OSSN is a tumor of the limbal stem cells. Then you have to finally excise it off the limbus under visualization. So these steps are followed in all patients. Then you excise it simply off the limbus under visualization. I use a wet technique. Even if you want to use a dry technique, that will be wet with blood anyway. It's best to see the base of the tumor when you excise it. That's the excision edge cryotherapy, where you wrap the edge of the tumor in a reverse fashion on top of a 3 millimeter cryoprobe and freeze it twice and thaw it spontaneously. This gives you an additional 3 to 4 millimeter clearance from the excised edge. Subclinical tumor will be taken care of by this modality. If you don't do it, then there is a higher chance of local tumor recurrence. Resection-based cryotherapy is not mandatory, but if you clinically see that, okay, base is slightly deeper at 1 or 2 particular clock hours, you can always do that. More than 3 clock hours of limbal cryo is not recommended. You should then wait for histopathology, and if base is positive, you should do plaque brachytherapy. Then how to repair the ocular surface is again surgeon choice. You can either use a conjunctival autograft from the same eye or the other eye if the patient permits, or use an amniotic membrane. We use a glued on amniotic membrane, which is very nice for the patient because there are no stitches, there is no irritation, and there is very good resurfacing of the ocular surface. Patients do well following surgery, and if you use OCT guided surgery, then you can actually predict the depth of the lesion. Now, what is relatively new is the use of primary simple limbal epithelial transplantation in patients who have extensive tumors, so that there is minimal complication of limbal stem cell deficiency. Surgery does remain an excellent choice. I have already spoken about adjuvant therapy. Let's see what are the cases which are beyond surgery. Patients who have tumors which are affecting the corneal stroma or sclera cannot be managed by surgery alone. They need something beyond surgery, and that is plaque brachytherapy. So plaque can be done secondarily or primarily. Secondly, when you excise this tumor, confirm it on histopathology that the base is involved, and then to that base you apply plaque after epithelialization is complete, after 3 to 6 weeks. That's one way of doing it. That is what has been done in all these patients. They have been doing well. And the second is to do primary plaque brachytherapy, specifically in patients who cannot stand a surgery. Why they cannot stand a surgery? Because you can see that there is already stromal melt. We don't know how healthy is the base here. We may actually have a limbal perforation which cannot be repaired. Patient may have intraocular extension. Then you do a primary plaque brachytherapy. Primary plaque brachytherapy is again a reality where you apply the plaque right on top of the tumor, either at primary surgery or even without doing surgery. Plaque has excellent success to the tune of about 90%. Now, there are very rare situations when there are advanced tumors. This young individual had multiple surgeries and had intraocular extension. He was referred for possible eye salvage. He was very keen on eye salvage. He had reasonable vision. The tumor, which had intraocular extension, was on the nasal side. His temporal retina was fine. His disc was fine. This is the kind of nasal retinal detachment he had. He had choroidal extension of the tumor, and he wanted to preserve the eye. He was very young, and we thought we would give it a try because OSS is a safe tumor. It doesn't metastasize so much. So we designed a radiotherapy field for him. We gave what is called chemoradiation, where he was injected cisplatin and given radiation at the same time. And after some time, you can see that retinal detachment has settled, and his choroidal component has completely reduced, and ciliary body component has also resolved, and it's remained so till date. So these are some of the innovative therapies which can be used for extensive tumors. Now, this is a patient with conjunctival melanoma, diffuse melanoma, with you can see intraocular extension. These are the ciliary processes that you see. This patient also had good vision, and he wanted to preserve his eye. So I'll skip the video. Basically, we excised this and then did what is called rotational plaque brachytherapy. So plaque was applied here, there, and there. So plaque has a particular dimension, so you have to repeatedly apply it to cover the entire base of the tumor. And this was at the last follow-up. He is doing very well. Vaporization of conjunctival tumors for lymphangioma, where you already know the diagnosis. Bleomycin is a possibility, but instead of using bleomycin so close to the cornea, you can always use vaporization technique. And target therapy is the last bit. This is a patient with conjunctival lymphoma with posterior extension along the surface of the eyeball beyond the equator. One option is to do radiation for the residual tumor, but here we choose perilesional rituximab, 5 mg per ml, 6 injections, 3 weekly, actually cleared the tumor. For conjunctival melanoma, we have the mutation and the treatment spectrum all worked out. There are many reports in the literature using pembrolizumab and nivolumab. This was our own patient, where the patient had regional lymph node metastasis, for which we started on nivolumab. He was admissible for nivolumab, and regional lymph node metastasis obviously started regressing, and his conjunctival melanoma also started regressing. So making a role for primary therapy of conjunctival melanoma with target therapy. So in conclusion, I would say that there are rapid new strides and paradigm changes in the management of ocular surface tumors. What is important is good clinical evaluation and imaging to determine the edge and base of the lesion. Then you decide if a particular patient is appropriate for topical therapy, whether it is interferon, 5-FU or mitomycin, depending on the patient profile and the ocular surface health, and or for primary surgery. When you do primary surgery, it is mandatory that you take care of edge as well as base clearance. Use histopathology as the guideline for adjuvant therapy, if any. That will give you much better outcomes. Thank you so much. Next speaker is Raksha Rao from Narayan Netralaya. She is going to show you a bunch of cases and discuss. I think you have 10 minutes.
Thank you, Dr. Honavar, for this opportunity. To be a part of your IC is a big deal on its own. Pen drive और ये attach कर सकते हैं? इस pen drive, PC, ये वाला, ये मैं कर लूँगी, वो आप कनेक्ट कर लीजिए. Okay, so starting with these 4 cases, 4 different pictures, A, B, C, D. So which of this is a melanoma and which is a nevus? So basically this is an amalgamation of whatever teaching that you heard over the last 1 hour from all these 3 eminent speakers. So I think you should be in a good position to answer this. A, B, C, D, which is a conjunctival melanoma? C. Okay, so of these 4 pictures, all are conjunctival nevus. Okay, so the picture A, there is prominent feeder vessels, but any conjunctival nevus up to 35% can have feeder vessels. Intrinsic vessels can be present in about 32% of the cases. And this particular nevus, which has a variegated pigmentation, some of them can be lightly pigmented, some of them can be darkly pigmented. And corneal invasion is basically seen in up to 1% of the conjunctival nevi. And deep pigmentation, what you probably guessed as a conjunctival melanoma, is very common in Indians, where as a race we are dark complexioned. Okay, so multiple lesions is seen in 5% of the individuals. Bilateral lesion can be seen in 1% of the individuals. So based on just presence of just few features, you can never differentiate whether this is a nevus or it's a melanoma. So basically, you must always decide whether it is a melanoma or a nevus based on 5 features, that is age, history, thickness, size and the number of feeder and intrinsic vessels, and the presence of cysts. Cysts is present in 63% of the nevi as compared to melanoma, where only 5% of the lesions can have cysts. Okay, so following the same protocol, this middle-aged gentleman who gives a history of prior excision therapy, excision biopsy, what is this lesion likely to be? Okay, so it's a middle-aged gentleman, there is a history of prior excision, definitely there is some thickness to this lesion, lot of feeder vessels, angry looking, and a bunch of intrinsic vessels as well. So the likely diagnosis is conjunctival melanoma. That's right. So conjunctival melanoma can also be just dark complexion, like these 2 cases where there is no intrinsic vessels, no feeder vessels, just a very darkly pigmented flat lesion without much thickness. But even in conjunctival melanoma, there can be 2 different types of diagnosis, like we have in case 1 and case 2. What is the difference between these 2 cases? Very similar looking, but there is a difference, a big difference. No. So the first case you see is a de novo conjunctival melanoma without any surrounding pigmentation, as you can see. In this second lady, this is a melanoma that is arising from a pre-existing PAM with atypia. So you can see that there is surrounding pigmentation, and this lady gives a history of pigmentation that was present since many years, and suddenly the pigmentation started to increase and grow, where retrospectively you can diagnose it as conjunctival melanoma that is arising from a pre-existing PAM. Okay, now this is a very intelligent adult patient who came with me, and in his very first visit, he came with a couple of pictures from his childhood. What he said is, since childhood, he had a small pigmented lesion, and this is how it looked like. And during teenage years, it grew bigger, and at the time of presentation, the pigmented mass was more reddish and, of course, much larger than the original pigmentation. So what is this? It's a conjunctival melanoma, all right, arising from a pre-existing nevus. Okay, so what you must remember is, anytime you see a nevus, the chances of it turning into a melanoma is very rare. It's less than 1% in Caucasians, and even lesser in Indians, but there's always a chance, so always have a lookout of it and keep the patients on follow-up. So this is a patient again with a very small pigmented lesion in the caruncular area with repeated history of bleeding. Looking at the size, you do not, and it's quite a young patient, about 18-year-old patient. You wouldn't think of melanoma, okay? What you would like to think of it as a congenital nevus, but there's a repeated history of bleeding. So for this reason, this lesion was excised, and it turned out to be a melanoma, a very small melanoma, which was a low-grade melanoma. So never forget to take the history properly. So now this is a lesion which is, of course, there is some whitish part, there is some blackish part. So what is this? Is it a melanoma or what is it? Any of the fellows at the back? Perfect, yeah. So this is pigmented OSN. What you cannot miss out is the presence of keratin. There is a conjunctival mass which is pinkish. On the left side of it, there is a dark pigmented part, and there is definitely this white keratin mass. So what you must remember is pigmented OSSN is present in Indians, and 5% of OSSN can present as with some pigmentation. So please do not just directly go to the diagnosis as a conjunctival melanoma. So this, there should not be any doubt. This is a, what is this? This is a white big mass. No? So what is this mass? Is it a conjunctival mass or? So basically you can hardly see the conjunctival mass as such, but the keratin production is so much. The lesion is completely covered with keratin, with angry looking feeder vessels going into the conjunctival mass. So this is an OSSN with a big chunk of keratin. Okay. So what is this lesion? No doubt with this. What is it? What color is it? Red, yellow, orange, a salmon patch? Okay, yeah. So this is a marginal B-cell lymphoma. So whenever you see a conjunctival lymphoma, always, especially when there is no discernible posterior border, always do a orbital imaging. So when I did the orbital imaging of this patient, what I saw was that there was thickening of the superior rectus. So basically this was an orbital lymphoma with a spillover into the conjunctiva. Of course, the patient underwent systemic evaluation as well, and the mediastinal and retroperitoneal lymph node involvement was seen. So the patient was treated with systemic chemotherapy and orbital radiation, and the patient is doing well. So what is this lesion again? Again a salmon patch with a feeder vessel. Yes, so this is a salmon patch. Again, it turns out to be a lymphoma. Again, on imaging, there was enlargement of the extraocular muscle, but however, the systemic involvement was not seen. So this patient was only treated after incisional biopsy, only with orbital radiation. Systemic chemotherapy was not necessary in this patient. So again, this is a patient with again a salmon patch with some amount of thickness. Again, it was B-cell lymphoma of the conjunctiva. However, there was no orbital involvement, no systemic involvement, hence the patient was only treated with excision biopsy. There was no need for any chemotherapy or radiation. What is this lesion? Is this red, yellow, salmon looking? What is this? Is this salmon? I don't think so. And what is the kind of the pattern of vessels that is present there? hairpin vessels. So this is a reddish lesion with some hairpin vessels. What is it most likely to be? Yeah, OSSN is a definite differential diagnosis, a papillomatous pattern, but this is a very benign conjunctival papilloma. Okay, yet another shiny reddish lesion with some feeder vessels in the conjunctiva. What is this? This would be difficult to guess, so I was not very sure of what this lesion might be. So after an incisional biopsy, I found out that this is an excisional biopsy, I found out that this is an IgG4 related conjunctival mass, and excision biopsy treated the patient completely. There was no adjuvant therapy necessary for this patient. This is unmissable. What is this? Yellowish lesion. This is a limbal dermoid. What is this? Lipodermoid, of course, it's again a variant of dermoid. What is this? Again a yellowish lesion, but it's an orbital fat prolapse. Again, this is a yellowish lesion. What is this? What is the difference between this yellowish lesion and this yellowish lesion? No, but there's a difference, right? The characteristic, you see, how is the conjunctiva over the fat looking? This is definitely angry looking, right? Lot of blood vessels. Okay, so this turned out to be a primary. Exactly, yeah. So Dr. Fairuz made a very good point here. So here you cannot see the posterior edge that well. Here you can see that there is a proper posterior edge. So this is basically a conjunctival mass with an overlying bunch of angry blood vessels. So this turned out to be a primary liposarcoma of the conjunctiva that was treated with excision biopsy and orbital radiotherapy. This very good. So I included this picture to show that pyogenic granuloma can look vascular like this or completely fleshy like this. So please have the differential diagnosis of pyogenic granuloma in any of the conjunctival lesions that you may see. And what I think this is one of the last cases. Okay, so what is this? A reddish lesion? Varix, yes. So orbital imaging is always necessary in a patient of varix to see how much of varix is present in the orbit itself. And to my surprise, on this orbital imaging, I found, what is this? What is this hyperdense lesion that you see along the inferior floor?
Phlebolith.
It's a phlebolith. Okay, so it's basically because of stasis of blood within the varix, sometimes there is occurrence of a phlebolith like this. Okay, what is this? This is the last case.
Nevus sebaceous.
Perfect. Who was that? Sir, aap the kya? You just want to finish this session, don't you? Okay, so Dr. Vikas has been right here. Yeah. So this is bilateral choristomas that the patient has. But what you must remember is when there is bilateral choristoma, patient, you have to look out for some hamartomas in the face, in the scalp and the neck region. So on examination, this patient had some amount of scarring in the conjunctiva, but on prodding a little bit more, he presented with his childhood picture, which had this typical nevus sebaceous of Hadossen. Okay, so in a patient with nevus sebaceous Hadossen, you always look for choristomas in the conjunctiva, which is usually bilateral. Okay, so yeah, this is post-operative. Yeah, thank you very much. Yeah.
Thank you, Raksha. Finished on time. Next, we hand over to Vikas Menon for his instruction course.